Hi, everybody. We'll go ahead and get started. We had a little bit of a clearing out of the room. Apparently, people aren't super excited to talk about STDs, but really, we all need to be talking about STDs. So we'll make this fun. We're going to talk a little bit about some of the current statistics that are available and why is this even part of this forum? Why are we even thinking about it? We'll talk about some populations at risk, which do include all of us in this room, some of the screening guidelines, and also the prevention strategies. So STIs are on the rise. So they are highest in teens and young adults, but we're seeing it in every single population. And there's been a 20% increase from 2015 to 2016 in those over the age of 45. So we think that STIs are something that just the teenage kids get, but actually it's really impacting everybody. There were over 2 million cases in 2016, which was a combination of gonorrhea, chlamydia, and surprisingly syphilis. And that is the highest in any single preceding year. So if we look overall at those 2 million cases, you'll see that the majority of them are chlamydia. That seems to be the most common one, but there are about 500,000 cases of gonorrhea, and again, surprisingly, 28,000 cases of syphilis, which is really interesting because about a decade ago, we used to think that syphilis was done and we didn't need to worry about it anymore. But clearly it's on the rise and it's something we need to bring back into our current thinking. If we look just at the state of California, what's surprising about it, again, it's kind of the same pattern of statistics, but we had almost 6,000 cases of syphilis in California alone in 2016, which is really a staggering number. So we'll talk mostly about the three different ones that are the most common: chlamydia, gonorrhea, and syphilis. So chlamydia is the fastest rising of all of them, mostly in young females, and part of that selection bias because we are targeting a particular screening population, so there's some selection bias there. And also we see it a lot in the African American population. And this is a trajectory of chlamydia from the year 2000 to 2016, and it's just a very beautiful, perfect straight line going up to the sky, unfortunately. For gonorrhea, we also have a very rapid rise, but instead of seeing it primarily in women, we are seeing it more in men. So there was a 20% increase in men from 2015 to 2016. Also in the African American population, and this is particularly troubling because there is a rising antibiotic resistance with gonorrhea, so we are running out of treatment choices. This is just a graph looking at gonorrhea, which we thought we had under control, but something happened in 2013, and there must have, I don't know, something very exciting happened in 2013, so we're having this dramatic rise. And then syphilis is the one, like I said, is just sort of surprising. We had a 20%, almost 20% increase over 1 year. And 90% of these cases are in males as well. Mostly men who have sex with other men. And 50% of cases also are HIV positive. Luckily, HIV is actually on the downward trend, which is a good thing. But these other three are definitely on the up. And then one of the most concerning parts about syphilis is the congenital syphilis, when syphilis is passed down from a pregnant woman to her newborn. And this has a lot of sequelae, including stillborns and neonatal deaths. And this really represents a systems failure. We are supposed to screen all women who are pregnant, and we'll talk a little bit about screening in a little bit. So if a woman is pregnant and either syphilis doesn't get detected or she doesn't get adequately screened, that's really a systems failure. At some point along the line, some ball was dropped. And it may have just been she never was able to access care, which is an overall bigger issue as well. And again, syphilis has a very fast rise. Yes? I would have to go back and look at it. Just when I was doing my research for the talk, it looked like the CDC because of these, and it may have been something that's relatively new, but I can certainly go back and take a look at that. Yes, and we.
Yeah, but I know there's some health systems in California that don't test prenatally for syphilis.
Which is really, so the CDC, so when I went through the most recent recommendations just preparing for the talk, they do recommend screening for all pregnant women. At least that's what they're saying on their website. Now, whether or not that's a change or whether or not states are interpreting that differently, that's a possibility for sure. But definitely, given what's happening with this congenital syphilis, it's something that we all need to keep in the forefront. So there are sort of two populations I'm going to talk to specifically today regarding STIs, and one is going to be the 15 to 24-year-olds, because this is the population where is the most common to have STIs. But what's interesting, so they account for about half of all the STIs, but they only represent about 25% of the sexually active population. But what is very interesting that I found was that this generation of millennials is less sexually active than the generation X and Y. And it's interesting because they generally are considered to have a more like laid back and sort of open sort of thought about sexual activity, but they are found to be less sexually active and have fewer partners. And in part, this is thought to be due to social media because there's less actual face-to-face interactions, less in real life interactions. And there's also this image that we project on social media that we have Instagram and there's filters on the photos and we're photoshopped. And so you meet somebody in real life and you're like, oh, well, you don't look like that. I mean, we can all look, amazing. I could look like Cindy Crawford right now, but, I don't have a filter on me. So it's kind of an interesting thing. So even though they're not as sexually active, we still are seeing this rise in this population. There are issues with insufficient screening, and it is recommended for all women to be screened less than age 25 for chlamydia. There's also a lack of access to care and concerns about confidentiality, of course, for teenagers. How do we get there? Are mom and dad going to find out? How do I pay for it if I don't use insurance? So they kind of are thinking about all of these worries. And then the other issue is on sex education, which I'm going to talk a little bit more in a bit, which really focuses on heterosexual activity and not on same-sex activity. So those who participate in same-sex sexual activity don't have the information in order to protect themselves. And only half of the states in the United States have mandated sexual education. So we have half of the states where we're not even sure where the information or if the information is coming. But interestingly enough, we're also seeing it in the older population. So syphilis tripled for those persons between the age of 45 and 64 from 2000 to 2010. And it really comes down to a lack of condom use. So they looked at men, and essentially 90% of the men they surveyed reported not using a condom, and 60% of women reported not using a condom. And the main issue is women aren't worried about pregnancy at this point, so they usually kind of think about condoms, birth control, pregnancy. They're not worried about it. And then men are fearful that this could potentially cause erectile dysfunction or make their erectile dysfunction worse. So why are these STIs on the rise in the older population? And it's in part, they're more sexually active. We have all these medications for erectile dysfunction. We're talking about vulvar pain and menopause. We're trying to address that with different treatments, so people are feeling better. The other issue is retirement communities. So we go from having less dense sort of housing into more dense housing. It's kind of like going to the dorms. So like, oh, this is exciting. It's kind of fun to think about. Amazing things are waiting for me. No, I'm teasing. So married, also a lot of this population was married prior to sex education really coming forward in the schools. And so they were married or that's something they weren't thinking about, and it's just not really on the forefront. There's also a weakened immune system, so we're just more susceptible. There is a lack of screening by providers. People just don't think about it. It's just not something we're thinking about with this population. And I literally just had a patient earlier this week who is 67, and we talked about a whole bunch of other issues, and at the end of the visit, I said, oh, it's so great we don't have to do your pap smear screening anymore. She said, well, Dr. Voedisch, I have new sexual partners, and I plan on being sexually active for a very long time. So I need to have my pap smear screening, and I need to have gonorrhea and chlamydia. And I was like, you are totally right. So that kind of shifted the focus of the rest of our visit, which was interesting that she was the one who advocated for herself. It was a definite, it was good for the gynecologist to have a little reminder. And then the other thing is being sort of divorced and widowed and re-entering this dating scene with all these online dating and the social media. there's a false sense of intimacy sometimes when you're chatting with someone over text or you're chatting on these apps, and then you sort of feel like you know them, but you really don't know them in real life. And so I think there's a little bit of, oh, I know this person, I don't need to talk about it, I'm sure they're fine. And so they're not talking about, oh, have you been screened, or even really thinking about it. It's sort of interesting when if we look at this graphic, you can see that the incidence of chlamydia are lower in the southern part of the United States, and this is due to a couple issues. In particular, those are where our retirement communities are. So I'm from Minnesota, it's freezing, everybody leaves in the winter, they go to Arizona, they go to Florida, New Mexico, and so that's where for some patients, where that dense sort of housing comes into play. And then also, unfortunately, these are the states where a lot of times access to healthcare isn't there, the quality of the healthcare isn't there, lack of sex education. So you're kind of seeing the impact of both the older population as well as the teenagers with this distribution. I wanted to talk a little bit about the history of sex ed, one, because it's super funny, and two, because it does parlay a little bit into sexually transmitted infections and sort of why we're seeing what we're seeing. So in the late 1800s, there was rapid urbanization where people were leaving the farms, which is where a lot of people got their sex education, watching farm animals, and sort of moving into these urban populations. So again, more densely populated. And then there was World War I that occurred, and there was rampant sexually transmitted infections in World War I. Syphilis was literally just like running through the barracks. And so there was a huge campaign within the military on sex education and trying to prevent the spread among the soldiers. And I love this graphic because it's telling women to stay away from the dance halls because all of these people have syphilis. So that was essentially what they were trying to say. There was a hilarious movie called Damaged Goods that was the first sex ed film, and it was kind of like the digital shorts we see before our feature film when we go to the movie theater. And it was about this very macho guy who was a cowboy. He decided to sleep with a prostitute before he got married the next day, and then his wife gets syphilis, and then his baby has syphilis, and the baby dies, and then he commits suicide. It's just like this super dramatic portrayal of what's going to happen if you have sex. So this was one of our first kind of interesting films into this, which I thought was fascinating. So the schools jumped on the bandwagon. They kind of piggybacked on the military and started doing these programs. And what's been really interesting is you would expect that there would be a general increase in quality of sex education from 1914 till now. But it is really impacted on the conservative and moral movements that are in the country at that time. And so in the late 60s and 70s, although we kind of think of this as a little bit more free love within the government, there was more of a conservative movement that was grabbing hold. And so this is where the population that we're seeing, the older population with the sexually transmitted infections, this was about when they would be getting their sex education, and they were impacted by the fact that this conservative movement was happening. And then sex education did come back to being really important due to the HIV epidemic in the 80s. We just couldn't ignore it any longer. So into the screening guidelines. So the CDC recommends everyone get screened for HIV at some point in their life. And for women, they recommend screening sexually active women under the age of 25. And on the website, it went through either all women less than 25, and then in another page, it would say sexually active women under 25. So there was a little bit of discordance on the website about that. And then also looking at older women who might potentially have risk factors and new partners or multiple partners, that type of thing. And then for pregnant women, and this kind of goes back to the point, is they recommend syphilis, HIV, and hepatitis B for all, and then gonorrhea and chlamydia for those who are considered at risk. But we basically screen everybody for gonorrhea, chlamydia in their first prenatal visit, and then repeat the testing as needed. And then for men, especially sexually active men who are bisexual, gay, or have sex with other men, they recommend annual screening for them as well. But otherwise, for other men, there is not a recommendation for annual screening. And then anyone who has unsafe sex or shares injection needles, they're recommended to get tested for HIV at least yearly. There are some limitations to the screening. All of these cases are reportable to the CDC and to the health department. They're supposed to go out and notify partners and making sure that everyone is getting their treatment. But because of this rapid rise, it's really hard for them to keep up with all of these new cases. And they basically have given up on chlamydia, so they don't even do partner notification for chlamydia just due to the sheer, in part because of the sheer number. And so one of the things to think about both personally and then as a provider is thinking about strategies for prevention. So one, just even having it on the forefront of what you're thinking about, either when you're seeing a patient or as a patient yourself, thinking about your risk assessment. Have I had anything new happening in my life? There's something I need to think about. There are pre-exposure exposure vaccinations that people can do, which we'll touch on in a moment. And then, of course, you just want to make sure that you're effectively identifying, diagnosing, treating, and doing the follow-up that you need to do for the patient in front of you, but also their partners. So it is recommended to give treatment to partners even if they're not your particular patient. And then there's also pre- and post-exposure prophylaxis, which we'll touch on. This is a great pamphlet by the CDC that I think if any of you are interested, one for your practice or just personally, you can find it on their website, and they have a downloadable version. But it's a really cool, just sort of succinct, these are the things you need to think about. And so it's something I'm going to start having in my exam rooms, just because I think it's something that patients can get a lot of information on pretty quickly. So male condoms are really the main, one of the main ways of preventing STIs. And what's been interesting is that there's been such a push with sex education on pregnancy prevention, and there's been such a push because we have much more effective methods of contraception than just condoms, that condoms have really been pushed to the wayside. People don't really talk about it. It's kind of an afterthought. They're like, well, you can go ahead and use a condom, but who knows what's going to happen because it may not prevent pregnancy, without thinking about the fact that they should be using a condom every single time for STI prevention, even when pregnancy isn't a concern. So when correctly used, they do decrease the risk of gonorrhea, chlamydia, and HIV, and they also help with other STDs, especially if there's an infected area or a sore that's being adequately covered. There's a lot of thought that latex condoms break or they're not reliable, but they actually are tested and regulated, so breakages are really rare. So when there's an infection, it usually is the result of inconsistent use, not using it either every time you have intercourse or throughout the entire encounter, or you're just incorrectly using it. There are polyurethane condoms for those with latex allergies, and those are very effective for STIs. But the natural membrane condoms, which are the lambskin ones, those are not effective for STIs. So they're effective for pregnancy prevention, but not for sexually transmitted infections, which is a little bit unfortunate because those are sort of marketed as being a more natural feeling, and so people more likely want to go towards that as their option. So one of the things to stress is that with each new act within a sexual encounter, you need a new condom. So if you're having both vaginal, oral, or anal intercourse within that encounter, each time you change, you need to put a new condom on, which people don't really think about. And how to correctly use a condom, you need to put it on when the penis is erect, but before any genital or oral or anal contact occurs, which a lot of people don't do. So they'll start to have intercourse, and then before ejaculation occurs, again, because they're thinking pregnancy prevention, then they'll put the condom on. And so that's part of that inconsistent use that we're seeing. And then one of the other things is also just properly sort of at the end of ejaculation and removing the erect penis and making sure you're doing it at the right time so that you're not having spillage from the condom as well. And the other issue is to ensure that there's adequate lubrication. And this, you can use water-based lubrications with latex condoms, but the oil-based ones that are out there are not, they will cause the latex condoms to actually break or have issues. So that's just something to kind of think about, especially if we're thinking about sort of postmenopausal and we have the vaginal dryness, we need to make sure that there's adequate lubrication so that the friction that's caused doesn't cause the condom to come off. And there are female condoms. They're a lot less popular. They were really popular back in the sort of late 90s. It's like this was going to be revolutionary, and they kind of fell off a little bit. So they're not as popular and they're not as well studied, but they are thought to be effective. And in sub-Saharan Africa, there's a big push right now for male circumcision because it's thought to reduce the risk of HIV, hepatitis, or HIV, herpes, and the human papillomavirus. And so there are a lot of campaigns for that, and that's something some people have been thinking about. And then rescreening after someone's been treated for an infection is really important. And often we would call it, come back for a test of cure. We want to make sure you've been cured. But it's not so much that the antibiotics failed, it's mostly that they're going back and having intercourse again with the same partner when everyone hasn't been adequately treated, so they're just getting reinfected in this cycle. And that's part of treating the partners as well. And then there's a push with this pre-exposure prophylaxis for high-risk populations. So for people who are at extremely high risk of, they're HIV negative, but they're at high risk of contracting HIV, they sometimes will do pre-exposure prophylaxis where they'll take antiviral medications even though they don't actually have HIV. So this comes up a little bit more in my practice with post-exposure prophylaxis. So unfortunately, this is something we need to think about for women who have undergone a sexual assault. And follow-up from sexual assaults is extremely poor. So once they're there and you have the patient in front of you, that's the time you really want to think about making sure that you initiate treatment, even if you don't have test results back. So you treat for chlamydia and gonorrhea and also trichomonas, which is another STI. If they haven't had the HPV vaccination, we'll talk a little bit about vaccines in a second, you want to get that started. Same thing for hepatitis B. And if they've had hepatitis B but they haven't been confirmed that the vaccination took, then they can get a booster at the same time. And then for pre-exposure vaccination, we need to think about the human papillomavirus, especially for women now through age 26 and men through age 21. This is a little bit, I know there's been sort of a pushback in sort of the anti-vaccination population, but the hope is to actually start the vaccination early, so by age 11 or 12, in order to basically intervene before individuals start becoming sexually active. And so it's hard sometimes for people to think about their 11-year-old becoming sexually active. It just is kind of a little bit overwhelming, but it is really one of the things that you can do to decrease both genital warts as well as cervical cancer. And then also hepatitis B and hepatitis A, you can also do vaccines for. So that wraps up our exciting sexually transmitted infection lecture, but the main sort of take-home points that I want people to think about is that STIs are on the rise. So this is not something that's a problem of a decade ago. It's something that's a problem now and is actually getting worse. And thinking about doing a risk assessment for all populations and not just when we think about the teenagers or those in high school. Following the CDC guidelines, which they do tend to make changes based on what their data, when their new data comes out, and a low threshold to screen and basically anyone else that you think might be at risk for STIs. And then also really focusing on prevention, so talking about education and counseling, talking about consistent condom use, going over how a condom works, even though we all think we know, and then looking at their vaccination history, making sure that they've been vaccinated, and making sure their partner's treated.